Greetings. Let me share with you how do you approach a patient with bright red bleeding per rectum, otherwise known as hematochezia. You want to find out whether they've just been passing bright red blood without any other symptoms. No diarrhea, no abdominal pain, no change in bowel habits recently, no weight loss. In that setting, plain hematochezia unaccompanied by any other symptoms, you think about the following possibilities. Number one, diverticular bleeding. Number two, angioectasias. And number three, always keep in mind hemorrhoidal bleeding. On the other hand, if the patient has history of any diarrhea accompanying with the bleeding or abdominal pain accompanying the bleeding, then you have to think about colitis. In an elderly patient, think about ischemic colitis. In a younger patient, you may want to think about inflammatory bowel disease. On the other hand, if the patient has a history of recent change in the bowels and comes in with bleeding per rectum, or if the patient has had some weight loss, then you have to think about the possibility of cancer. So, the bright red blood per rectum without any accompanying symptoms, think about diverticular bleeding, angioectasias, hemorrhoidal bleeding. If they have pain abdomen or diarrhea, think about colitis, either ischemic colitis or inflammatory bowel disease. If they have had any recent change in the bowel pattern and have lost weight, think about cancer. In addition to these different types of pathologies that could account for the bleeding, you also want to know about the past medical history. Was there any bleeding in the past? Did the patient ever had any ulcer in the stomach or liver disease, prior history of inflammatory bowel disease? And also keep in mind if the patient has had any abdominal surgeries, especially aortic aneurysm repair, or if the patient has had cancer, did the patient receive any radiation? If the patient had a recent colonoscopy and comes in with bleeding, you should think about post-polypectomy bleeding. So, we talked about different ways you can figure out the most likely diagnosis, and also by taking the past history of peptic ulcer, liver disease, and IBD, you would know whether there's any other possibility. Always keep in mind the possibility of a AAA aneurysm rupture, something to keep in mind. Another important thing in terms of evaluating a patient with a bleed is how is this patient going to do, whether he's going to recover and go home or is he at a high risk of significant morbidity and mortality from the bleed. It all depends upon whether the patient is healthy or has serious comorbid conditions like heart disease, pulmonary disease, renal disease, or liver disease. Anytime a patient has severe underlying comorbid condition, a bleed is likely to be life-threatening in these patients. Hence, when I see an elderly patient or any patient with serious underlying comorbid conditions, it's important to make sure that you proactively manage them. consider resuscitating them quickly, and consider intervention, either endoscopic intervention or whatever intervention is necessary to stop the bleeding. The longer you wait, these patients with comorbid conditions are likely to succumb from that bleeding. It's also important, as you've gone through the past history, the comorbid history, important to not forget about their medication history, especially whether they've taken any non-steroidal anti-inflammatory drugs, because they can cause ulcers anywhere in the GI tract, and those ulcers could bleed. So important to ask about non-steroidal anti-inflammatory drug use, or NSAID use. Also, find out in an elderly patient whether they are on any antiplatelet therapy or antithrombotic therapy. Why is this important? If the patient is on non-steroidals and develops a bleed, it's important to educate them about avoiding non-steroidals, because these patients are likely to come back with a repeat bleeding if they continue to take NSAIDs. Why is it important whether the patient is taking antiplatelet agents or antithrombotic agents? If you do not manage or resume these antiplatelets and antithrombotics as soon as possible after the bleed has been controlled, these patients may succumb to that bleed, either with a heart attack or with a stroke. So important to keep in mind whether the patient is on antiplatelets or antithrombotics, and have a game plan to manage them once you have controlled the bleeding. So in summary, whenever you see a patient with hematochezia, you want to ask a simple question. Is it a healthy patient who comes in with hematochezia, or is it a patient who has hematochezia with comorbid conditions that put them at high risk, in which you have to manage them aggressively, and also whether they're antithrombotic and antiplatelet drugs? That has to be kept in mind in managing their vascular disease. And knowing the patient, not just the bleed, helps you come up with a comprehensive management strategy. I hope this is helpful. Thank you.